Good afternoon, everyone, and welcome to this Moffitt Cancer Center Facebook Live event. I appreciate you joining us for this Ask the Experts Q&A. We have a nationally recognized malignant hematology program here, which specializes in the diagnosis and treatment of blood cancers and autoimmune disorders. And we have 5 of Moffitt's world-renowned experts here today to answer all of your questions on this subject. Before we dive in, though, into the Q&A, I want to thank all of our viewers for being here and remind you of just a few ground rules as we move forward. Remember, we cannot offer any diagnoses over Facebook on your specific condition. At the end of the Facebook Live, we will share some links where you can contact the hospital and make yourselves an appointment. And also remember that Facebook Live is a public forum, so everything that you do post and share is out in the public for the world to see. So please keep that in mind as you watch as well. So jumping in, I want to introduce Dr. Jeffrey Lancet, who is the chair of the Department of Malignant Hematology. And Dr. Lancet, I was hoping you could give us an overview of the department and also introduce our panel today.
Yeah, no, thanks so much, Steve. Hi, everybody, and thanks for joining in today's event. My name's Dr. Jeff Lancet, and I'm the chair of the Department of Malignant Hematology here, as mentioned by Steve at Moffitt, and it's my pleasure to be here and to help get this program started. First off, thanks, Steve, and your team and colleagues here in the strategy group for organizing this event, and big thank you to any of the patients, families, friends, colleagues joining us on the call today. So before I turn it over to Dr. Komrokji, let me just give you a brief introduction to our department and our program. We are a very large and diverse clinical and research enterprise here at Moffitt, focusing on the diagnosis, the treatment, and even the prevention of blood cancers. We treat exclusively blood diseases. We see over 3,000 new patients per year in our program, and we have the most comprehensive portfolio of clinical trials anywhere in Florida. And these range from cutting-edge immunotherapy and targeted drug trials to trials that actually focus on quality of life. So we really do it all here with clinical trials. Our program is broken down into 3 sections or teams, which you'll hear much more about in the next few minutes. Each team taking care of a specific category of diseases. We have the plasma cell myeloma team. We have the lymphoid cancer team, which takes care of primarily lymphomas and other lymph node-related diseases. And the myeloid team, which takes care of patients with diseases such as acute myeloid leukemia, myelodysplastic syndrome, myeloproliferative neoplasms, and others. And each member of these teams, from the physician to the APP, is super specialized in those diseases only. So our patients are truly getting care from providers who exclusively take care of their specific disease, something you really won't find outside of a large academic cancer center like Moffitt. So today's session, I think, is going to focus mainly on clinical care. We are going to plan a future session that does a deeper dive into some of the research going on here within the hematology program at Moffitt, both laboratory-based and clinical research. So please stay tuned for that in the future. But for now, I'd like to turn over the program to the Vice Chair of the Department of Malignant Hematology, here with us today, Dr. Rami Komrokji. He is also a world-renowned expert in myelodysplastic syndromes and other related diseases. And he will be introducing you to some of the disease-based leaders in our program, and to give you some familiarity with these individuals and the diseases they treat. So thank you very much for being here. And please go ahead, Dr. Komrokji.
Thank you, Dr. Lancet. Good afternoon, everyone. And it's a real pleasure to be here on live with our patients and their families. I would like to introduce the 3 panelists who are really our experts and lead our efforts in each section. As Dr. Lancet mentioned, we are super specialized. So our department is divided into 3 sections based on diseases that best serve the patients in a super specialized way. So today we are joined by Dr. Rachid, who's the head of the myeloma section. Dr. Baz is world-renowned also in myeloma and has been at Moffitt for a long time, conducting clinical trials, seeing one of the largest numbers of patients with multiple myeloma. Dr. Javier Pinilla, who's the head of the lymphoma section that deals with lymphoid diseases, also world known for his work in CLL and CML. And last but not least, Dr. David Sallman, who heads our myeloid section dealing with the AML, MDS, and his really work in P53, a very difficult group in MDS, AML, is world known as well. So hopefully those panelists will be able to answer many of the questions and shed the light on some of what we do.
Thank you, Dr. Komrokji, and thank you all for joining us for this Facebook Live. And I want to remind everybody who's watching that if you do have a question for our panelists, please drop that question into the chat box below the window as you're watching, and we'll do our best to get to everybody's question as we discuss this department and what it is that they do. And thank you, Dr. Komrokji, for that overview. And I wanted to start with you with one specific question that I have and that I've asked many times in my work here, the Public Relations Department here, is and I'm going to ask for a simplified answer to this. I know it's not a simple question, but what exactly is malignant hematology? A lot of people think, oh, it's a blood cancer, which is not incorrect. But I was wondering if you could kind of expand a little bit about what that definition is for our patients who are watching.
Right. So obviously, the department actually serves more than just malignant hematology. Malignant hematology is a term that refers to any sort of blood cancer. However, as just by the organization of our department, blood cancers come in different types. So we have the leukemias, the MDS, which are like, part of the bone marrow failure. We have the multiple myelomas that originates from plasma cells, and the lymphoid tumors, like the lymphomas. Each of those diseases actually are many categories. They all manifest in a way of abnormal blood counts, lymph node involvement, and other symptoms. But our department also sometimes serves and helps also with pre-malignant conditions, conditions that can lead to those situations, like in multiple myeloma, for example, something called MGUS. That's an abnormal protein detected in the blood that those patients are at risk of developing myeloma later on. And we also sometimes also take care of patients with, benign conditions, not cancer that leads to low blood counts. So it's really a spectrum of things that we cover.
And thank you. And I know it's, like I said, it's a very simplified answer of everything that this department does because there is so much. And of course, I wanted to bring in some of our other panelists here. And since we were just talking about multiple myeloma, excuse me, Dr. Rachid Baz is here on the line with us. And Dr. Baz, I was wondering if you could give us a little bit of an overview of what it is that you do in the multiple myeloma space here at Moffitt Cancer Center.
Hi, thanks, Steve. And, good afternoon, everybody. Yes, I'm a myeloma doctor. I've been at Moffitt for 15 years. But, as Rami mentioned, we look at plasma cell disorders as a spectrum. And on one end of the spectrum is multiple myeloma, which is a cancer of the plasma cells. But on the other end of the spectrum is precursor conditions such as MGUS, monoclonal gammopathy of undetermined significance, smoldering myeloma, solitary plasmacytoma, but we also see patients who have systemic amyloidosis as well. And between us and the department of, the lymphoma section, we actually see patients with, Waldenstrom's macroglobulinemia. So I typically manage those patients, the spectrum of conditions, and, we do clinical research, that involves, patients with these disorders. I tell patients a lot of time, my job's easy. I only tend to deal with one specific part of, hematology or oncology, but in reality, a lot of times in the community doctors are dealing with, breast cancer, lung cancer, colon cancer, and, the field's evolving in all of those areas tremendously. So I think having this super specialized approach to each condition is definitely a plus.
And this is perfect timing. We just had a question come in from one of our viewers, and Dr. Baz, I'll stay with you since it does deal with multiple myeloma. Is there a worse and better case scenario when it comes to multiple myeloma? Like, are there different types? And what are some of the, I guess, what does that spectrum look like?
Yeah, absolutely. I mean, so that's why we a lot of times call it multiple myelomas. There's really, multiple different ways that it can impact patient. It's a disease that can be very heterogeneous. A lot of patients could have a chronic disease type illness where we can manage it for sometimes many decades, and then patients could, have other medical problems that become more serious. Alternatively, it could be a condition that is very difficult and hard to treat at times, and where we really need, desperately, better medicine. So in reality, it's kind of the spectrum, and we have, fortunately, a lot more, on the chronic disease paradigm, that these are patients that we can, give treatment periodically and, control the disease for long periods of time.
And again, reminder to our viewers who are watching this, every case is individualized, of course, and your course of action would be personalized to your current situation. But we're doing the best we can to kind of generalize this for everybody, which is certainly a challenge. So thank you for that answer, Dr. Vaz. I appreciate that. I wanted to shift over a little bit and shift gears to Dr. Sallman. Dr. Sallman, I see that you have joined us, and I wanted to touch a little bit on leukemia. You are the section head which is involved with leukemia, and I was wondering if you could give us an overview of what it is that what that means and what leukemia is.
Yeah, sure. So, I mean, we've already heard that we're dealing with blood cancers and essentially acute leukemias. And then, we talked now a lot about myelodysplastic syndromes, which are really diseases of a spectrum. Even actually, recent classifications, there are groups of patients that really are called MDS/AML, just kind of highlighting that spectrum and somewhat arbitrary divides if you have a blast cutoff of 20% and have acute leukemia, or 19% and called myelodysplastic syndrome. But essentially, we all have stem cells. These are our early cells that give rise to all of the other, mature cells, our red cells, our white cells, our platelets. And essentially what happens is you get a mutation in one of these stem cells, and these stem cells grow sort of uncontrollably, and essentially leads to presentations where your other good counts are not doing well. So you may present with fevers, infections from having a low white count. You may be tired, short of breath, functional status decline from the hemoglobin drops, bleeding or easy bruisability from platelets. And then there's a whole host of presentations. I think one of the challenging parts for patients, particularly that are dealing with these type of cancers, it really can impact every facet, of their life. But essentially, again, is a mutation-driven disease that ultimately has consequences based on inadequate, good cell production.
And what is so amazing to me that, all of these cancers are similar yet so different, which of course is why they're all under this umbrella. And I'll be honest, I'm going box by box as we do this conversation, and I have Dr. Pinilla next in here. And I know your focus is lymphoma. You're the section head of lymphoma. And same question for you, Dr. Pinilla. Tell us a little bit about what it is that you do and what lymphoma is and how it's different than these other blood cancers.
So once again, thank you, Steve. Thank you for this invitation, and definitely as all my colleagues in this program really have been describing other conditions. We are really talking about lymphomas and lymphoid diseases, and I think we need to really go to the basis that the stem cells really can differentiate in different types of cells, right? And we have the myeloid cells that will really get rise, as Dr. Sallman and Dr. Komrokji said, MDS, myelodysplasia, acute leukemia. You have these plasma cells that can raise to really multiple myeloma, and you have these lymphoid cells that can really produce leukemias, really chronic or acute lymphoid leukemias, as well lymphomas. And lymphomas, we really define lymphomas as a cancer of the lymph nodes, right? We all of us have lymph nodes, and inside the lymph nodes, we have a lot of lymphoid cells, mostly B cells, because we have two main types of lymphoid cells, B and T. And these B and T cells in the lymph nodes mainly, and sometimes in the blood too, get rise to a high variety of conditions. Really, maybe it's the large really amount of diagnosis between one section, right? We have more aggressive diseases, more indolent diseases, and diseases in between. And that's the reason that we have specialists in each of these area of lymphomas, or even certain lymphoid leukemias, who really give us the strength of knowing how best to really treat each of these patients. Because again, our heme pathologists are very, very well trained to differentiate very, very specific types of lymphomas, because different types of lymphomas may really need different type of therapies.
Right, and thank you for that answer. And I see a lot of questions coming in from our viewers, so thank you, viewers. Please send those our way. And Dr. Pinilla, since I have you, this question actually came in specifically for you. It's from Teresa, who's watching, And she asks, how important is it to cell type Hodgkin's lymphoma, cell A or large cell B, when determining treatment options?
Yeah, well, once again, I think Hodgkin lymphoma is a subtype of lymphomas in general. And for example, I will have to say that there's also different types of Hodgkin lymphoma, even in this condition. But obviously, you have to differentiate with something. Other most common lymphoma is diffuse large B-cell lymphoma. So I think, once again, the pathology examination by a very well-trained hematology pathologist is really a fundamental aspect of really knowing what is the right diagnosis for these patients to really indicate the best therapeutic strategy.
And I know this is a question I've asked a lot of you over my time here in public relations. You hear about Hodgkin and non-Hodgkin. What is the simple answer to determining what the difference is between those two? Because I know it's very complex, but what's the
Right. So for sure, Hodgkin is defined by Hodgkin cells. These are very specific types of cells that we encounter in these patients, right? Mainly seen in younger patients, very curable condition, by the way, but need really adequate therapy because there's several times. And non-Hodgkin is referred to any other things that doesn't have these Hodgkin cells. And there's very, very large amount of diagnoses that comprise this category, from, as mentioned before, for very, very indolent and really kind of quite slow-growing diseases, are very, very aggressive conditions that require very, very immediate therapeutic treatment.
Yeah, thank you for that. And again, I know it's complicated, so thank you for making it easier for us to understand. Dr. Baz, we had a question come in that I believe would be appropriate for you to answer for us. Sam in Sarasota asks, for MGUS or smoldering myeloma, is there other treatment other than monitoring every 6 or 12 months? And could you expand a little bit on what that cancer type is?
Yeah, so for most patients with MGUS and smoldering myeloma, the standard of care is monitoring. And it's a little bit, counterintuitive, as the person who asked the question mentions, because a lot of times we hear, well, if there's a condition in the bone marrow, why don't we intervene early? But in reality, the reason that we don't intervene is that, a lot of those patients will never develop myeloma in their lifetime, and, intervention may cause side effects. And the second reason is that we haven't proven that intervening makes a difference for a lot of those patients' outcomes. And I think that is important. Now, studies are actually underway currently to look at specifically high-risk smoldering myeloma patients who might benefit from an intervention to prevent, them to develop myeloma in the future. But these still are underway. There has been some success in that field, but those successes are not things that we have adopted in the clinic because there's still a lot of questions to be answered. And some of those, treatments, may have side effects and implications for the long run. So because of that, the standard is still to observe and monitor, although in the future, that might change. And specifically, if we're able to identify ahead of time who are those individuals with those precursor conditions who will later on develop the cancer, and we would intervene for those patients only. That would be, I think, the better approach overall. And there's a lot of studies that are ongoing at Moffitt and elsewhere that are looking at that.
And to follow up on that, Dr. Baz, I believe you answered this, but Peggy asked directly, is it MGUS? Does it always become myeloma? And if I understood, you just said it does not always become myeloma, right?
That is correct. It may not. The rate of progression is about 1% per year on average. So if somebody gets diagnosed with this at the age of 60, then in the next 20 years, we typically estimate that about 10 to 15% will develop myeloma. That most of the patients don't develop myeloma. And it's not exactly 20% because other things in life become more serious when somebody reaches around 80, or before even, for that matter. So as a result, most of the patients with MGUS will not develop myeloma.
Thank you for that. And Dr. Komrokji, I wanted to ask you this question, and if you're not the right panelist, please direct me to the right one. But Donna is asking about hemoglobin, and she asks, is 16.4 hemoglobin for a 71-year-old woman a concern? And can you talk a little bit about what hemoglobin levels are?
Yeah, absolutely. So obviously, as mentioned by Dr. Sallman, The red blood cells usually carry oxygen in the blood. If they are low, we say somebody is anemic. If they are on the higher end, we say they are polycythemic. So there is excess increase in the production of the red blood cells. And that could be actually a condition that could be a blood cancer, that there is overproduction in the bone marrow, a condition we call polycythemia vera. But many times that could be a secondary or a compensation from the body for a condition like, if somebody have obstructive lung disease, asthma, smokers, there are certain medications that can cause that. So our task is always to evaluate, is this a problem in the factory that there is increase in the production in the red blood cells, or this is just a reaction or compensation from the body for a condition that's causing low oxygen. A hemoglobin of 16 and above for ladies is considered in that range.
And another question that's kind of related to that, Dr. Komrokji, while I have you, is I know hemoglobin is discovered through blood tests, things like that, but are there ways for, I guess, what are the symptoms of some of these cancers that we're talking about? Can people notice these things before they do a blood test and know to get assistance?
Right. So obviously for anemia, which is low blood count, so the red blood cells or the hemoglobin will be low, the symptoms are really not specific. In general, profound fatigue, shortness of breath, palpitations. If somebody goes a flight of stairs, they will feel tired. For the increased production in the red blood cells, sometimes patients will get headache, numbness, pain in the hands or feet. But most of the symptoms are actually not very specific. And most of the time, we catch many of those things by the routine, testing that the primary care physicians do on an annual basis. But those are some of the symptoms.
And thank you for that. And of course, as with any cancer, if you notice any symptoms where you notice a change, definitely talk to your general practitioner so they can refer you to the right specialist. Dr. Sallman, I wanted to bring you back in on the conversation a little bit. And as we shift gears here, I know a lot of people, when they hear about blood cancers, specifically like leukemia, they think of transplantation and stem cell transplants. I was wondering if you could talk a little bit about who's eligible for specific stem cell transplants and if there are different kinds.
Yeah, sure. That's really a great topic. So, transplants come a long way. So I think if you even asked a decade ago, many people would say, once you're over the age of 60, that transplant's not an option. That age cutoff actually continued to be defined. Actually, I would argue that maybe there's not really a strict cutoff. So just as an example, there was a really high-profile paper published in patients with, let's say, high-risk myelodysplastic syndromes, where up to the age of 75, patients were transplanted. And really, the survival improvement is quite dramatic in patients that ultimately go to transplant versus not. In many patients with acute myeloid leukemia or myelodysplastic syndrome, transplant really brings forth our only curative option. There are subsets of acute leukemia that may be able to be cured by chemotherapy alone, but that's actually quite rare, and actually a lot of those patients end up being younger as well. So transplant is really a key part of being at a center like Moffitt, because these things have to go hand in hand. Actually, even before we come up with their first therapy, we're often discussing transplant. We're super specialized here, so we have our own transplant group, and we actually have our own transplant providers that solely focus on patients with myeloid diseases. So as we're starting our first treatment, in that first couple of weeks to first month, they're seeing them. They're undergoing some basic workup to see about finding their donor. And really, it's just a key aspects of all parts. And one really critical thing just to mention is that this really needs to happen from the beginning. I think far too often I get referrals, maybe patients later in therapy, and also what could this patient be a transplant candidate? Unfortunately, the best time to transplant patient is often sort of in the setting of best remission from first-line therapy. So these things really need to happen from the beginning. Of course, we're always offering trials and salvage therapies to try to get patients there even after first line, but really having this part of the sort of standard of care from the beginning is a critical part of care.
And thank you for sharing that, because again, like I said, with the question, everybody always goes to transplant first. Is kind of how our minds work. So thank you for clearing that up. And talking about treatment, and I'm not sure who to pitch this one to, so I'm going to throw this one out so whoever wants to answer. I want to talk a little bit about chemotherapy because it has been mentioned a couple of times. And one of our Facebook viewers is asking, does some chemotherapy cause neuropathy? And I believe they're specifically asking about the drug Revlimid. Hopefully I'm saying that correctly. Who would be the appropriate person to answer that question?
Yeah, that sounds like it's me. So some of our myeloma therapies cause neuropathy, and Revlimid is not the main one for this. Bortezomib, Velcade, is the more notorious one to cause neuropathy. Revlimid can cause some paresthesias, although they usually don't get severe. Revlimid is a derivative of thalidomide, and thalidomide caused neuropathy, but we rarely use thalidomide nowadays. I would like to make a point about the term chemotherapy because, I think we've kind of, as a field, adopted the use of, the term anti-cancer medicine, because a lot of times people have in their mind that impression of chemotherapy being, what was given in the 70s for patients with testicular cancer, and the patients, lost all their hair and had a lot of nausea. This is not what we're using anymore for the treatment of myeloma. That's only in the context of transplant do we expect hair loss. Outside of that context, we don't usually expect hair loss. Those anti-cancer medicines are, more biologically, targeted. They're, immunotherapies as well. And so we've kind of moved away from the term chemotherapy because it can be misleading. Now, it doesn't mean some of our therapies don't have side effects. Of course they do. And it's always, the management of those side effects becomes the most critical aspect of any kind of, patient, management, because not only we want to give treatment, but we also want to make sure it is given safely.
Absolutely. And I'm glad you pointed that out. Chemotherapy is a blanket term that's not so accurate anymore. So thank you for sharing that. And I have to train myself to use anti-cancer treatment. So thank you for that. Staying kind of on that same theme of treatment, Dr. Pinilla, I had a question come through that I believe would be appropriate for you because it has to do with Hodgkin's lymphoma. Teresa is asking for a friend who was just diagnosed with Hodgkin's lymphoma stage 4, and Keytruda is being part of the treatment. She's curious about how Keytruda works with lymphoma. Is it common? Is it a new way to treat it?
Yeah, absolutely. So talking in general about frontline treatment for Hodgkin lymphoma, and as we discussed, chemotherapy still works, but true in lymphoma as well in myeloma and other conditions that we are really dealing in malignant hematology, we are really bringing more and more new therapeutic strategies, and Keytruda is one of them. Keytruda is become a really, really important part of the immunotherapy for solid tumors, right? For all metastatic, cancers like melanoma, lung, and so on. It's very interesting because in the world of the lymphoid malignancies, I will even also say that in the plasma cells and the myeloma malignancies, this type of therapeutic strategies are not being as successful yet. However, mainly the best example of the success has been Hodgkin lymphoma. So PD-1 or Keytruda or all the drugs that really work in the same way are able to really wake up the immune system, the innate of the really immune system of the patient, and attack the tumor, right? We still try to really define which patients, for sure, patients with Hodgkin lymphoma can be done. Many times it's not being used in the front line, although in certain older population can be used too in front line, but most of the time it's used in the second or even third line as a rescue, because obviously there is other therapeutic strategies that works very, very well in this setting. The same condition, the same drugs may not work in all types of lymphoma, but there is subtypes of non-Hodgkin lymphoma that these drugs really work. But right now, the world of immunotherapy in lymphomas really took off through monoclonal antibodies, bispecific antibodies, and very, very well popularized CAR T cell that we may explain later.
Wonderful, and thank you for that answer. And please, viewers, keep dropping those questions into the chat. These are fantastic. I'm learning right along with you. Dr. Lancet, if you don't mind, I'd like to bring you back into the conversation. It's kind of like a larger overview of immunotherapy in the world of malignant hematology. I know immunotherapy is on everybody's minds when it comes to cancer care. What does that landscape look like currently in your area?
Yeah, it's a great question, Steve. Thanks. Immunotherapy, I think, is a very broad-based term for lots of different approaches to therapy that involve some type of manipulation of or effect on the immune system. And that can range from simple antibody-based therapy, where an antibody basically recognizes a cancer cell and attacks it and kills it either directly or indirectly, to something much more complicated like cell therapy or CAR T therapy, which some of the colleagues on the line today are more experts at than I am, but it basically reflects a reprogramming of the patient's own immune system to recognize and fight off cancer cells. It's been particularly effective in lymphoma and multiple myeloma, not quite as far along in the myeloid diseases. But other types of immunotherapies besides CAR T therapy, such as antibody therapies that are linked to a toxin, are often used in myeloid leukemias and also in lymphoma and now myeloma. Those can be effective. We have something called bispecific antibodies, where you have an antibody that targets the cancer cell and also targets a T cell to bring those cells into close proximity to allow the T cell to more efficiently kill the cancer cell. So those are a few examples of immunotherapy, and they've definitely, and I didn't even mention some of the more traditional immunotherapies that have been, more commonly used in other cancers, like pembrolizumab. These are PD-1 and PD-L1 inhibitors that kind of turn on the immune system after it's been turned off by cancer, and those are being used more in the lymphoma field in particular than they are in the myeloid or the myeloma field. But in general, immunotherapy is a very important component to cancer care. It can be used in isolation by itself, or it can be combined with other forms of more traditional therapy to help fight off cancer. And I'll just finish by saying that allogeneic bone marrow transplant, I think, is kind of the boldest and still maybe the most widely used form of immunotherapy in some of our fields. And we know that it is immunotherapy because it reduces the risk of relapse in many of these myeloid diseases. So some of these other immunotherapies are trying to mimic the effects of the transplant without all the toxicity and the cumbersome nature of the transplant. So immunotherapy is very important, but it's definitely emerging in our field as it is in the other fields.
Right. I know that we, of course, all rely, rightly so, on our doctors to know what's best for us, but doctors are constantly learning as well, mostly through the help of like clinical trials and things like that. So I wanted to shift the conversation a little bit here. And Dr. Sallman, if you don't mind me picking on you again, I wanted to ask a little bit about clinical trials in MDS and AML. I know there's certain scenarios that work best for a clinical trial. Could you talk a little bit about that?
Yeah, so I think, when you really get into the nitty-gritty, I think really at all aspects of care, from first-line therapy through, again, patients with relapsed refractory disease, we should always be looking for clinical trials. I think, as was alluded to a little bit by Dr. Komrokji in the beginning, you take P53 mutant MDS AML, it's a group of patients that has a, median overall survival of somewhere less than 6 to 12 months. And again, for that group of patients in particular, you really need to be thinking about clinical trials at all times. And really one of our main missions, I'd say within the heme department and the myeloid section specifically, is to be able to offer a patient at any time point in their care a clinical trial, because really we're very much trying to improve the standard of care. And again, for many of these diseases, I think our standard of care is particularly subpar. Just to give a very brief, discussion, you'll hear different phases of trials. So, earlier phase trials, we're often trying to find the dose, understand the safety. A nice advantage is there's no placebo. Many times these are very common, particularly in patients with relapsed refractory disease, where there is no standard of care whatsoever. Whereas in patients often in frontline, we're more kind of in phase 2, trying to learn, is this new combination, does it look much more exciting or not than the older combinations? And then to phase 3, where we're really, pivotally going to decide whether or not this new, combination or therapy represents a standard of care. And we help, lead and participate on all of these trials. And really, the challenge is, even if you get one day of therapy, that may exclude you from some really exciting trials. So, we really very much push as much as possible. If we can see patients even before, their initiation of therapy. And again, many patients may get treated locally. We work hand in hand with many of our local oncologists throughout the state, Southeast, and nationally. But again, being involved from that very beginning is quite critical to choose the best therapy up front.
Thank you for that. And while I have you, Dr. Sallman, we did have another question come in that asks about stem cell transplant. So you may be the right one to answer this. Benny is saying that it was suggested that bulking up on your weight prior to a stem cell transplant is recommended because you can lose a lot of weight. Is that a valid suggestion?
I think, what can patients do? Because everybody wants to ask, they really want to be as involved as possible, with the process. And I really say two things to all my patients. They can eat and they can walk. So really their exercise capacity is quite important. That can obviously be challenged based on their symptoms related to their low blood counts. But very much, their nutritional, particularly protein. A lot of patients will have wasting. They may have needed to be in the hospital for a long time, and all of that kind of makes this downward spiral. And actually, a lot of patients, they may not even be able to go to transplant because of such impairment, and really to become eligible, they need to improve that. But there's no question, the more that we can do to bolster the sort of nutritional status and functional capabilities of our patients, that is absolutely key. And my patients that are functionally and nutritionally better, clearly do better. And again, that's I always tell them that's their job. Unfortunately, through that whole process, and sometimes can, of course, be very challenging on a patient-by-patient basis.
Of course, I'm glad you brought that up, because every patient I've ever met wants to know what they can do to make the doctor's job easier. So I appreciate you saying that. Dr. Baz, I believe this question would go to you, since it's asking about multiple myeloma. Tasha, who's watching us, asked, if you do not have any symptoms of multiple myeloma, is there any test to see if you have those traits? It's a great question.
Yeah, I would say a lot of patients nowadays are diagnosed in the absence of symptoms. That didn't used to be the case. I'd say, 10, 15, 20 years ago, we saw more patients who were diagnosed when they were very ill, hospitalized in, kidney failure, etc. But we do see a greater proportion of patients diagnosed without symptoms. However, myeloma is an uncommon condition, and so there isn't a screening that is advocated or advised for patients with, no history of myeloma, that, to have specific testing. So if the patient has a precursor condition like MGUS, then they are getting screened, or tested periodically and monitored. If the patient doesn't have any such history, then we don't advocate testing, asymptomatic patients, because there is, low likelihood that we're going to detect something, and it's not proven that could improve outcomes. So because of that, screening is not recommended for the population.
Thank you for answering that. That's a great question, because I know, in the world of cancer, early detection is key. You want to do what you can in order to be aware of what may be going on with your system. So thank you for answering that. This is a question about CMML, which I believe is chronic myelomonocytic leukemia. I know I didn't say that right. So Bambi Lynn from Facebook is asking, are there any new trials in that space for CMML? I'm not sure who that would go to.
I'm sure. Yeah, I'm happy to take it. I think, Dr. Komrokji and I have been working on a lot. So I'd say the one thing is actually Moffitt has been one of the only centers in the world that has run CMML specific trials. So for example, Dr. Padron, who's our translational lead here and really has a pure passion for improving the lives of patients with CMML, has now run several trials with a JAK inhibitor, ruxolitinib or Jakafi, showing actually quite comparable response rates as where that agent is approved in other myeloproliferative conditions such as myelofibrosis, polycythemia vera. So I think the challenge is, and this is just where we're at, is, hydroxyurea, which is really just a pill with some, blood count lowering abilities, has never definitively been beaten in a clinical trial, even with some of our other standard of care low-dose chemotherapy, such as hypomethylating agents like azacitidine, decitabine. So again, this is another key patient population, of course, a very rare group of patients that quite urgently, needs to think about clinical trials, from the get-go, and a lot of times thinking about out-of-the-box approaches. Clearly, transplant still a curative option for this group of patients, but really medical-based therapies are quite underwhelming, and we, at the center are kind of hyper-focused on making that change.
Thank you, Dr. Sallman, for taking that. I thought you were the right one, but I wanted to be sure. It's great having all these resources right here. we're almost to the tail end of this Facebook Live. I did have another quick question for Dr. Pinilla about lymphoma. Is lymphoma considered a curable disease at this point?
That's a great question, Steve. As we've been discussing through this program, lymphomas is a very large amount of conditions that really comprise multiple diseases. And as mentioned before, some of them, they are really very indolent, or they are really not really aggressive, and as such, they are not really what we call curable. While others that may be more aggressive or really have a different intermediate kind of behavior can be curable. We were really discussing previously, as an example, Hodgkin lymphoma is a curable disease, typically found in younger population, and we know that the curability with standard chemotherapy with some form of immunotherapies, they are really high, in the 80–90% in some populations, right? While other conditions, we know they are not curable. However, the fact that they are not curable doesn't mean that they are not treatable. And I think it's another very important concept that really are we bringing to the practice these days. We tell to the patient, okay, you have this condition, we cannot cure, we cannot, as Dr. Bass was telling you, we may not even treat you at diagnosis because there is no benefit of survival. However, if the time comes and patients really require therapy, well, we can really prolong the life of our patients for many years through the new strategies, new biologicals, and new target therapies that we have. So once again, it's not really a single answer for these questions. It's very much dependent on the type of lymphomas that we are dealing with.
Thank you for that, Dr. Pinilla, and thank you to everybody who's been sending in these questions. They've been fantastic. Before we wrap up, I wanted to circle back to you, Dr. Komrokji, and ask if there were any parting shots you wanted to share with us today about the department as a whole, about anything that's on the horizon. Just wondered if you had any brief thoughts before we say goodbye.
Yeah, thank you. So obviously, I think we highlighted a lot of the stuff. I think the message in general that really we've had improvement in the outcome and treatment for our patients over the last few years, with the introduction of several of the treatments that my colleagues introduced. So in leukemias, for example, MDS and AML, in the last 4 or 5 years, we've had several new drugs approved that are really changing the landscape, shying away from the classical intensive chemotherapy we do. All of those were possible through clinical trials that many of them were conducted here actually at Moffitt. I think we touched base a little bit about some of the super specialized treatments we offer, such as transplant, but also the CAR-T. The Moffitt program had been leading the development of this in lymphoma and acute lymphocytic leukemia. The other thing I would mention is we also, keep track of all our patients as a group and their outcomes. So we have those large databases that we examine the outcome for patients, and we learn a lot in answering questions that clinical trials sometimes don't. So for example, there was the case of CMML brought up today. This is an ultra-rare disease, but Moffitt hosts the largest database, internationally, where we could go back and look at the treatments, the outcomes, answer a lot of questions that help other patients. So I think the take-home message is really that outcomes are really improving in malignant hematology in general. We have cutting-edge treatments shying away from chemotherapy, and outcomes are definitely improving. As all my colleagues stressed, I think those are super specialized diseases that, in my opinion, it always helps the patients to seek at least a second opinion, make sure they are on the right track, get verification of the pathology, and they can continue the treatment locally if it can be done there. But I definitely think that this is particularly an area where a second opinion is very helpful.
And that's a very valid point. And Dr. Lancet, before we say goodbye, I wanted to give you a chance to share any last minute thoughts as well with the panel and also with those who are watching us on Facebook. Any last thoughts from you?
No, not too much. It's been a pleasure to be here today. I also learned things listening to these guys talk, which is always a good thing. I would reiterate Dr. Komrokji, what he just mentioned about the importance of getting a second opinion for blood cancers, really all cancers, at a large center, if at all possible, because there are such nuanced approaches now to taking care of these cancers that are so individualized that treatment options may be different after a diagnosis takes place at a major cancer center as opposed to perhaps a community center, and that being seen at a place like Moffitt can enhance the care, not detract from it or necessarily change it, but can add options that a person can consider later on down the line. And I feel like it's good for our patients throughout the area to be plugged into a center like Moffitt so that if they need perhaps more specialized care in the future in the form of clinical trials or transplant, that they're already part of the system, part of the family, and can be treated quickly whenever necessary. So I think that that aspect of it, as well as the clinical trials options, really provides cutting edge therapy options for patients. And it's not for everybody, but to me, it makes sense to explore those options to their fullest whenever a cancer diagnosis is made, especially blood cancers.
Of course, and I know we just scratched the surface today of everything that this department does and what you doctors specialize in. So I thank you so much for taking the time out of your very busy schedules to share your expertise with our Facebook Live viewers. And thank you, viewers, for tuning in. I want to say thank you to Dr. Baz, Dr. Komrokji, Dr. Lancet, Dr. Sallman, Dr. Pinilla for your expertise here today. And thank you to everybody watching. Remember, you can get more information about the Malignant Hematology Department and all things Moffitt Cancer Center online at moffitt.org. And you can also link from that page to our new patient hotline. So if you are in need of our expertise, please give us a call. Thank you so much for tuning in today, and everybody have a wonderful afternoon.